is titled Health, Medicines, and Food in South Asia. What we eat, how we eat, where and when we eat are all deeply embedded in cultural practices. To that end, most traditional food systems view food as being inseparable from medicine and regard medicinal foods as the front line of healing. In the next three sessions, the three reports that you will be hearing, you will see a comparison of traditional beliefs and practices and health-seeking behaviors that influence dietary practices during pregnancy of South Asian women, both a comparison between India and the United States by Monica Satyamurthy, who is a master's student in nutrition in the Department of Public Health, Food Studies, and Nutrition. Then we have Karen McNamara, who is a PhD student in anthropology at Syracuse University, who will be talking about Bangladeshi garment workers and their experiences with food and health. And then finally, Japna Dhillon will be presenting dietary habits and practices of South Asian female students as they move to the United States and what sorts of challenges they experience. So, Monica.
Hi everyone, my name is Monica again, and I'm a second-year nutrition science graduate student here. And today I will be presenting traditional beliefs, practices, and health-seeking behaviors that influence dietary practices during pregnancy of Asian Indian women in India and the United States. This topic is of great interest to me because I grew up in India and I watched the women in my family and the women around me follow certain traditional beliefs and practices, which made me want to explore the root causes of these cultural traditions. As we know, during pregnancy, a woman's nutrient needs are increased, and studies have shown that Asian Indian women follow and practice various beliefs during their pregnancy because it's believed to be beneficial to the mother and the baby. The population of Asian Indian immigrants in the U.S. is increasing, so it's important to learn about the constraints faced by Asian Indian immigrant women in accessing maternal health care. Some of the constraints are due to settlement issues, language barriers, acculturation, and conflicting belief systems. Healthcare professionals have raised concerns that babies being born to Asian Indian immigrant women are at a higher risk for low birth weight, malnutrition, and genetic abnormalities. So there are very few studies in the U.S. That have examined the knowledge and cultural traditions that surround Asian Indian immigrant women's pregnancy experiences, their social support and health-seeking behaviors, and the ways that traditional beliefs and practices are accepted and incorporated into the healthcare context. Previous studies on this topic have usually examined rural populations, and only a few studies that thus far have studied urban Asian Indian populations. And what makes this study unique is that it compares the Indian population and the US population regarding their beliefs and practices. So this is a forgotten community and needs more attention right now. This study aims to increase the nutrition professionals' knowledge of Asian Indian cultural beliefs and dietary practices related to pregnancy in order to aid in effective dietary assessment, counseling, nutrition intervention strategies to promote a healthy pregnancy. The research objectives of this study were to examine Asian Indian women's healthcare practices during pregnancy, to identify and describe the traditional food practices, beliefs, and behaviors that Asian Indian women practice during pregnancy and their impact on pregnancy, to identify the challenges that Asian Indian immigrant women experience with regard to healthcare during pregnancy, and to compare traditional practices, beliefs, and behaviors during pregnancy between Asian Indian women in Bangalore, India, and the immigrant women in Syracuse, New York. So right now, statistics show that India accounted for a quarter of the global maternal mortality burden Apart from the direct causes of maternal mortality, studies suggest that indirect causes such as access to and availability of healthcare services could lead to maternal mortality. Asian Indian immigrants, depending on their socioeconomic status, are likely to experience multiple barriers to healthcare access, such as language, cultural familiarity, area of residence, financial barriers, and also the use of non-Western medicines. Immigrant populations in North America represent a pluralistic health society where people follow both Western and traditional medicine, such as Ayurveda. Ayurveda is the most commonly practiced form of medicine in Asian Indians. So why do people seek alternative treatments? It could be due to dissatisfaction in some way with Western medical treatments, or it offers more personal autonomy and control over healthcare decisions, or it's more compatible with patients' values, worldviews, or other beliefs. And studies have shown that healthcare professionals have disagreements over the use of non-Western medicines, such as Ayurveda, because they think it's not an appropriate healthcare behavior. So it's necessary for healthcare professionals to gain knowledge on the culture of an individual in order to better understand their actions and behaviors. For example, some of these women classify foods as hot or cold, and I don't mean temperature-wise, and this concept stems from Ayurveda, which considers illness to be a result of an imbalance of body humors, which disrupts health. A major objective of this study was to compare quantitative and qualitative evidence of the traditional beliefs, health-seeking behaviors, and food-related beliefs during pregnancy between two groups of urban Asian Indian women from India and the Asian Indian immigrant women in Syracuse. Approximately 50 Asian Indian female respondents were recruited from each country to participate in a survey. And for the qualitative phase, 5 females from each country were randomly selected for an in-depth interview. The population were selected by convenience sampling. These areas were selected due to familiarity of the place, social networking connections for sampling, and experience of working in that area and population. One way to make sense of this complex environment is to apply it to the theory of reasoned action. So 106 Asian Indian women completed questionnaires regarding the traditional beliefs and practices during pregnancy, which was framed within and adapted from the TRA model. The primary focus of the model is on attitudes, beliefs, and intentions. A person's intention and their health beliefs are influenced by 2 key factors. First, their level of intention is greater if they have a positive attitude about the behavior. Second, their level of intention is also greater if they're motivated to comply with the social norm. So one of the aims of this study was to identify demographic factors such as age, level of education, etc., that influence pregnancy-related food beliefs, and this model was used to explain certain food avoidances and certain food inclusions based on these beliefs. The results of this study revealed that the majority of the Asian Indian women studied do conform to some, if not all, traditional beliefs and practices. The dietary aspect of these traditional practices were adhered to the most part, and this rather limited the food choices of the women during pregnancy. In most cases, significant differences were observed between independent variables such as age, level of education, region of ancestry, and so forth, and behaviors such as health-seeking behaviors and food beliefs. So this was the model that was adapted from the TRA model. As you can see, the inherent values such as family, religion, and cultural beliefs were influenced by their demographic characteristics, such as mainly age, length of residence, education, region of ancestry, and dietary preferences, which combined to influence the woman's attitude and health-seeking behavior, health maintenance practices, and food beliefs. For this presentation, I'll be highlighting the food beliefs section. So the respondents from India indicated significant agreement regarding food beliefs such as papaya and sesame seeds, if consumed during pregnancy, cause abortion. And clarified butter, which is ghee, is good during pregnancy. And eating cold foods such as milk and yogurt has a cooling effect that is beneficial during pregnancy. So as you can see, the food-related beliefs are split into two categories. One is food-related, pregnancy-related food beliefs and humoral-based food beliefs. And under humoral-based food beliefs comes the hot and cold, which falls under the Ayurvedic system. So in regards to the humoral-based food beliefs, hot foods were seen as harmful and hence avoided during pregnancy, while cold foods were believed to be beneficial. So the respondents from India classified foods as having humoral properties. So they reported grains and spices as being hot, and they tend to avoid that during pregnancy. And then they consume dairy products and green leafy vegetables, which were cold foods, a little bit more during pregnancy. So as you can see, this can lead to food avoidances and food inclusions, which have advantages and disadvantages. Disadvantage being that it can cause nutrient deficiency and inadequate dietary intake during pregnancy, and advantage being that certain foods consumed during pregnancy as a practice have beneficial health impacts. So this is the same model for Syracuse, and the differences that we're seeing with this population was that Syracuse respondents indicated a significant higher agreement for food beliefs such as iron content and poor availability from foods is a major cause of anemia in pregnant mothers. Almonds help in fetal brain development, and cardamoms and cloves help in digestion. So you can see that the respondents from Syracuse tend to believe in more evidence-based beliefs because they came here and they started to acculturate with the Western society, so they tend to base their knowledge more on what the society believes. In terms of the humoral-based food beliefs, they believe that animal products and tropical fruits were hot foods, and dairy products and temperate foods were believed as cold foods. And Asian Indian immigrant women have unique cultural beliefs, attitudes, and perspectives toward health, illness, and healthcare practices. Of most concern is their lack of essential vitamins and minerals in these women's diets during pregnancy. The effect of such deficiencies could be directly related to public health problems in the U.S. and requires further investigations. So by understanding the cultural beliefs and practices of Asian Indian immigrant women, healthcare professionals can develop education materials that are culturally specific and can be provided with the involvement of key people from the family and the community. So recognizing and respecting traditional practices and including family and community members will enhance the woman's sense of well-being.
Our next presenter will be Karen McNamara.
I have no slides, so you just have to listen to my story. I happened to visit the clinic of the Government College of Unani and Ayurvedic Medicine on a Thursday and was surprised by what I found. On other days when I had visited this clinic, it was almost empty. But on that Thursday, it was packed with at least 50 people, predominantly women, in brightly colored cotton sharis and shalwar kameez. They were sitting calmly and patiently in orange plastic molded chairs, waiting for their number to be called so that they could be seen by a traditional practitioner on duty that day. This government teaching hospital clinic is in Mirpur, a growing and bustling area in the northern part of Dhaka, the capital city of Bangladesh. The area is known for the numerous multi-storied cement garment factories that tower over other buildings. The college and clinic are at the end of a long and busy two-lane road. with shopping complexes, government buildings, and NGO offices lining both sides. I quickly learned that because Thursday was the one-day weekly holiday for most garment workers, it was on this day that many walked in droves to visit the clinic. Why do patients, mostly women garment workers, come to this government clinic that only dispenses Ayurvedic and Unani medicines? What kinds of illnesses are these patients seeking care for, and what forms of care are they receiving? In my longer dissertation chapter, I focus on two interrelated arguments. I reveal how the consumption of Unani and Ayurvedic medicines is one of many issues at stake in terms of illness and care in this clinic. The space and practice of traditional medicine in this government clinic are marginalized within the wider public health structure. The uneven access patients have to different forms of health care reveals the buyer power of the state, because certain illnesses and certain clinical spaces and medicines become reserved for the poor due to a particular intersection of the history and the politics of this local ecology. However, for this short talk, I will focus predominantly on the importance of a more nuanced understanding of patient agency as it relates to social suffering and interactions with physicians in the context of care in this clinic. This Unani and Ayurvedic clinic is a government clinic that provides nominally cheap health care. Patients have to pay 6 taka, which is less than 10 cents, to buy a ticket to be seen. Many of the women aren't even aware that it is an Ayurvedic or Unani college hospital clinic, but they do know that it is a government clinic and come because it is affordable and in their neighborhood. The location of this clinic is important because for most patients, it is around a 20 to 30 minute walk from their homes, which saves them from spending money for a bus or a rickshaw. Also, word has spread that they can get good care in this clinic and that they are treated well by the practitioners. The clinic provides a limited number of free Unani and Ayurvedic medicines, although the practitioners do sometimes refer patients to buy other medicines at a nearby pharmacy. The garment industry entered the urban landscape of Bangladesh in the early 1980s, when the country was ruled by a military dictator and was extremely dependent on foreign aid to keep the government afloat. This aid dependency and global deficit forced Bangladesh to adopt structural adjustment programs, which opened up the economy for foreign investment and export-oriented production. This new industrial policy was supported by the World Bank, and the Bangladeshi state gave numerous incentives to entrepreneurs who decided to invest in Bangladesh. In 1981, there were only 21 garment factories, but in 2010, there were over 4,000. Today, the garment industry accounts for a large percentage of the GDP, with factories exporting $5 billion worth of goods to countries all over the world. Women make up around 90% of the more than 2 million garment workers. Initially, no special economic processing zones were created, but instead, factories were built in an unregulated manner in both residential and commercial neighborhoods throughout the major cities of Dhaka and Chittagong. During my fieldwork in 2008, an article published in a popular Bangladeshi newspaper described an outbreak of ghost panic in over 10 garment factories near Dhaka. Workers fainted after seeing ghosts or corpses in the bathrooms of the factories. According to the article, a manager in one of these factories reacted to the situation by giving in to workers' demands to arrange a full-day recitation of the Quran in the factory, to start the construction of a mosque on the grounds, and to bury amulets around the factory to keep evil spirits at bay. Workers at this factory complained that there were only 2 doctors and 2 nurses for the 14,000 workers, and that they were rarely available when needed. In my interviews with garment workers at the Mirpur clinic, similar problems with medical officers in the factories also came up. Mohammed, a 24-year-old married man who worked in the garment factories, came to the Mirpur clinic because he had been sick with a recurring fever and bowel problems for 3 months. He said because of his work, he never found the time to come to the clinic, and even though there are terms and conditions to be able to see a doctor at the factories, he had never been able to. He said, quote, "The medical officers only sit at the factory once a week. If they come and sit once a week, we don't receive the news that they are there. The management doesn't tell us. If we get sick and go there, they don't have the medicines, don't treat us, or they aren't there, so there is no benefit, end quote. So if the garment workers don't have access to health care at work, what do they do when they become sick? How do their illnesses become embedded in their social suffering and follow them into other spaces and social interactions outside of the factory? Many garment workers are unionized, and there are often public protests and riots that have led to negotiations and increased wages. The conditions of their work and the manifestations of resistance are always changing. However, even though there are forms of resistance to the ruthless work regimes of factories, such as protest, fainting, and spirit possession, most men and women still continue to work every day and endure the conditions of their work, illness, and suffering. In their narratives, most women attribute the environment of the city and their work as the contributing factor to their illness. They often talk about city living in stark contrast to memories and experiences of village life, where they were healthy and able to eat well. Not all the women I spoke with worked at garment factories, but the majority did. A woman named Ruby came to Dhaka 2 years ago to work in the garment sector. She's from a village near Bogra, a city in the northwest of Bangladesh. In her illness narrative, she connects her physical ailments to mental ailments. She says, I came here for medicine, to take medicine. I work at the garments, that's why, so I get durable, weak. My body gets weak. Everyone comes here. They say the medicine is good. They get better. I'm coming here after a month. Amar shorir durable chilo. My body was already weak then because I go to a doctor every 3 months. They give an injection so that you don't have babies, end quote. Sometimes patients do know the names of the medicines they take. Rubina is one of the few who mentions that she likes the medicines because they are herbal medicines. She says, if you get a ticket, they give you medicine 3 times. I took medicine for durbalata. I took it 3 times a day. I got better. I keep taking the medicine. One was amloki, the other one, I don't remember what it was called. This medicine is good. I take medicine that is made from plants. I could eat better. I had shadabang, which is white discharge. It got better. I got better by the will of Allah, end quote. She then goes on to describe her life in her village home. She says, I only had a little bit of sickness there. It was healthier in the desh. And desh means like you're in village home. In Dhaka, I haven't gotten jaundice, but I can't eat properly here. I work in the bright lights. That causes tension, stress, no? Chintabhav, worries. Also, my son is getting older, but he still lives in my village, end quote. Rubina's description of the desh, or her village home, as a nostalgic place where she belongs to, is also voiced by many other women. The time spent in the desh is seen as a time and place to recover from the sickness and suffering caused by living in urban Dhaka. Even though there is still sickness and there are many health problems in rural areas, many women describe the desh as an idyllic place where they don't get sick, or at least not with the same kinds of illness as in Dhaka. As Shahana, a woman who has lived in Dhaka for 2 years, says, I didn't really get sick in the village. Sometimes I had a fever or a headache. Now I have jaundice here in the city, but I never had it before. I could eat rice in the dish. There is wind, fresh air there. After coming to Dhaka, we work inside with electricity, lights. That's why there's a lot of sickness here now. Shahana later goes on to say, my body is weak. I never had to take medicine for this before. In the dash, I would take medicine for fevers, napa. But in the village, we did not get sick that much. When there was lots of rain and we played in the rain, then sometimes we'd get sick. It's really hot in Dhaka City. All day I work. It's so hot in the factory. What a situation. Hot and lots of lights. I can't eat properly, end quote. She goes on to talk about how her job involves printing. She puts the color on clothes. She says that the clothes are on a table and I print the color on them with a helper. I used to hem the collars of shirts at a different garment factory, but then I got really sick and I couldn't eat rice or water. So I quit that job. Then I went home to my desh for 2 or 3 months, got better, and came back to Dhaka. It is clear in these narratives that women directly connect their sickness to the conditions of working in garment factories and living in the city. It is the intense light and heat, the lack of fresh air, and the long hours of hard work in the factories that they contrast with the fresh air and open space of the dish. Often the women describe not being well or being sick and metaphors of not being able to eat properly. In this context, this common metaphor may need to be read in a more literal way, as a lament about the lack of time and labor to cook, and even the erasure of the desire to eat. Many women discuss their lack of time or energy to even cook a meal. They do not explicitly say that they cannot afford good food, but they don't feel like eating. As Asma says, I cook, and when I'm sick, my husband does. I come home at 10 at night, cook, eat, and sleep. After being sick for a few days, I don't like anything at all and can't eat. I don't feel or want to eat. And she says, like, kette monetaina. Another woman, Amina, says, my body has no strength. No, Allah knows. No strength in the body. I'm hungry, but I can't eat anything. I took some meds from here, and I got a little better, end quote. Often the free medicines the women receive from the clinic are vitamin tonics. The medicines do provide some nutrients, but are not a cure for their problems, but only a salve for never-healing pains. In medical anthropology, resistance to political power is usually formulated as resistance to specific diagnoses, prescriptions, or norms of behavior, or official accounts and records. Therefore, these forms of resistance are to different types of medical authority. The relationship between doctors and patients is usually an uneven power configuration. Therefore, patients often resist the medical authority of a doctor by not following their recommendation or by using a prescription in an unintended way. According to Kleinman, noncompliance is a form of resistance especially used by patients from the lowest socioeconomic classes who are structurally more vulnerable to poor health due to conditions from political economic change. In his work on power relationships between practitioners and poor patients in rural Bangladesh, Wills also emphasizes how it is the power of the diagnosis that constructs a patient's weakness. And durbalata means weakness. So how can we understand the role of agency in pain configured as human suffering when it does not involve some form of resistance? What does it mean when these garment workers self-diagnose as weak and actually seek out medical care for their suffering? I see the garment workers' temporary encampment in the clinic as lodging a public complaint, even though no formal or written complaint is made. The word lodge usually conjures an idea of a formal complaint that is filed with an official or with the court. Instead, I'm using the word lodge to mean to inhabit or to be encamped in a space temporarily. When the patients voice their self-diagnosis and self-presentation of weakness, they're acting from their own power and agency. These women workers do not view their weakness as intrinsic to themselves, but understand their weakness as directly related to outside forces, such as their work and their living conditions. This understanding of weakness by these women calls for a reformulation of the meaning of the encounter between the patient and the practitioner in the context of the local ecology of this clinic. Even though there are more women than men who come to the clinic, both men and women present a self-diagnosis of weakness. In the context of this clinic, I do not think durbalata can be read as simply a form of medical dominance with no clear therapeutic value. Instead, the self-diagnosis and presentation of weakness is a way for the patients in the Mirpur clinic to voice their suffering and to get recognition and care, even if they do not have a specific bodily ailment. At the clinic, someone listens to their complaints and expresses empathy in the form of mostly free medicines and various vitamin tonics. Perhaps because of the urban and public nature of the Mirpur clinic, the dynamic of the power relationship between the practitioner and the patient is different. The practitioners I spent time with are very aware of the commercialization of healthcare, especially in urban Dhaka, where there's a pharmacy on every corner and numerous diagnostic centers and private hospitals mushrooming all over the city. As one practitioner told me, quote, "My job is mostly mental support, and this medicine helps a little bit for some sicknesses," end quote. In addition, the practitioners who work in this clinic are government employees, and so their salary is not based on the number of patients they see. The actions of the patients in the Mirpur clinic show that not all agency is necessarily empowering or a form of resistance. The patient's voicing and lodging of their complaints is empowering to a certain degree, but still does not necessarily change the patient's relationship with the practitioner, the conditions of their work, or the policies of the state. Therefore, this example shows how agency can be disempowering, but that does not mean that a person is completely passive. A person can be disempowered and enabled at the same time. Assad explains that agency in pain and suffering is often problematically theorized because ideas of progressive agency are an attempt to eliminate pain and suffering. To illustrate his point, he shows how in many religious traditions and other contexts, pain can actually be central to agency and not necessarily a cause of action. Pain has also generally been theorized as something that is resistant to language and is a private experience. Assad differs by explaining that pain can be fixed or experienced through a process of structuring the experience of it, the pain. I'm arguing that even though the experience of pain is voiced individually to the practitioners in this clinic, it is not just a private experience. Instead, it is a public act and experience, because the act of coming to the clinic and temporarily lodging the space, not alone, but in small groups that form a larger group in the clinic, is a process of structuring the experience of pain for many of the patients. It is in this space where the pain can be communicated in the form of illness to the practitioner. This process creates a shared space and experience. The focus on the process is important for formulating agency, so that agency is not understood as a simple Cartesian dualism between individual actors versus structure or doctor. Instead, the process of becoming conscious of these relationships brings another dimension to self-awareness and agency. The locus of this awareness to act in a certain way is often not just an individual person, but can be generated by institutions or occur among a group of people, as in this clinic setting. In the midst of their suffering and pain, patients show their resilience by coming to the clinic. Although it is not emancipating them from the situation that is causing the pain, by voicing their complaints, they are actively doing something that will make them feel better, even if it is only temporary. Coming to the clinic to lodge their complaints and to seek care is a significant act for these workers as they continue to negotiate their everyday struggles. Thank you.
Now we have Japna Dhillon, who will present on dietary habits and practices of South Asian female students in the United States.
Hello, everyone. I'm Japna Dhillon. I'm a second-year master's student in nutrition science, and I'll be presenting on the dietary habits and practices of South Asian female students in the United States. This topic is very dear to my heart because I'm a South Asian international student as well, and Dr. Raj is kind to give me the opportunity to do some research on this. The research objectives of my study were to determine the role that knowledge and, I've never used this thing before, so I'm just trying to make it. Oh, it goes backwards, okay. So the research objectives of my study were to determine the role that knowledge and perceptions of food choices play in influencing the dietary habits of South Asian female students in the United States. Also to determine the challenges faced in adopting healthful dietary practices and whether there is enough motivation to adopt such practices and or maintain traditional ones. I think that was, sorry, the second slide. In addition, I also did a survey and a food frequency questionnaire to determine the current patterns of dietary intake and also evaluate the diet quality of South Asian female students studying here, and also to examine the dietary habits and practices of, in general, of all South Asian women, as well as the beliefs. Before we begin, I'd like to give you a short background introduction about why I did my research. So So minorities such as Hispanics, African Americans, Asians, and others make up about 34% of the population in the United States. And Asian Americans are the third largest minority group here. There's approximately 2.7 million South Asians living in the US, with Asian Indians forming the majority of the South Asians. So this regional diversity, in addition to the religious diversity as well, determines the dietary practices of South Asians. So as South Asians immigrate to the United States, they undergo a process called acculturation, which Monica explained in her study as well. And dietary acculturation is a process by which immigrants modify the traditional dietary practices and adopt those of the host countries, in this case, practices and dietary patterns of the United States. It's multidimensional, dynamic, and complex, and it's influenced by a multitude of factors such as personal, cultural, and environmental attributes. It could be age, length of residence, employment status, income level, your traditional attitudes and health beliefs, religion, and also availability of traditional food. Dietary acculturation is the major determinant of health risk behaviors amongst immigrants, and it could lead to poor dietary practices, lack of physical activity, and increased fast food intake. As a result of dietary acculturation, there have been studies that have shown that Asian Indians may experience dietary acculturation by modifying their vegetarian status, altering meal patterns, changing the frequency of use of ethnic foods, and adopting foods from other cultures as well. There's this perceived model minority notion of the South Asian American community being very wealthy and healthy. As a result, this leads to their needs being overlooked. And there has been limited attention paid to researching the health status, including dietary acculturation of South Asians in the United States. So according to the Slutzker Center of International Services, which caters to the needs of international students here at Syracuse University, Syracuse has a population of about 1,450 international students, and those from South Asia make up more than 1/3 of the total international student population. And studies have also shown that international students face challenges such as culture shock, language problems, cultural differences, a lack of social support network, differences in healthcare, access to healthcare, and as well changes in the physical activity patterns. As a result, they tend to overlook their dietary habits, often at the risk of jeopardizing their own health. And some of these changes, such as a high alcohol intake, increased body mass index, modified dietary practices, which could be in addition of new foods or missing certain meals, modification of existing foods, and rejection of traditional foods. This could set the stage for the development of chronic diseases such as obesity, diabetes, or cardiovascular diseases. And other studies have suggested that students often skip meals, especially breakfast. There's also a decrease in the total number of meals. There's an increased consumption of fats, salty, and sweet snack items and dairy products. And they're also less willing to try out new foods and opt for American fast foods or processed foods while eating out. The reason why my study focused on women was because men and women differ in their acculturative dietary behaviors. And there's a study on international students in Belgium that observed that men were more likely to make dietary changes than women. And women tended to attach more value to healthy eating than men and refrain from making healthy choices due to maybe perceived unavailability of healthy food. There are also certain social, economic, and behavioral factors that play a role in these health disparities. And South Asian women traditionally are primary caregivers for the families, and that makes them more sensitive to certain cultural barriers as well. And some South Asian women immigrants are reported as experiencing unnerving circumstances, which is also called acculturative stress, despite having a strong social support network. In general, Asian females who've been living in the United States for a decade or longer had an 80% higher risk of developing breast cancer than recent immigrants. And women, again, in general, are more predisposed to certain diseases such as breast cancer, anemia, and osteoporosis than men. So this was the dietary acculturation model that was adapted from a study done by Satya Nabuda. So you see on the left, there's socioeconomic and demographic factors. Then below you have the cultural factors, which on exposure to the host culture result in changes in psychosocial factors and taste preferences. And there's also change in values ascribed to traditional eating patterns and taste preferences again as well. Other changes could be changes in environmental factors, and that leads to changes in how these women might procure their food or how they might prepare their food as well. So eating out behaviors change, traditional perceived unavailability of traditional foods is another factor. Accessibility of food and affordability of food is, again, some factors that influence this dietary acculturative process in South Asian women. As a result, you notice different patterns of dietary intake, which could be either maintenance of traditional eating patterns or adoption of the host country eating patterns as well. So my study had a mixed methods design. I had a quantitative component to the study, which involved the survey, which looked at demographic factors, lifestyle, factors related to health, health maintenance practices, and nutrition belief practices as well. I also did a food frequency questionnaire to determine the dietary diversity and dietary variety, which I'll be talking about later. And we had a 3-day food record just to validate the initial data collected from the sample. Whereas the qualitative methods comprised of the focus group, where, again, we use the focus group to validate some of the data that we collect from the survey and also to determine some challenges observed by these women in the United States. So my study had a cross-sectional component where we examined the dietary practices of South Asian women who were already here at that point in time, and a prospective component where we followed some women, the recently arrived South Asian women, over a period of 4 months to determine the change in their practices. We initially recruited about 150 South Asian female students studying at Syracuse University, and they were recruited by the Slutsker Center for International Services. And this estimation was based on the total number of students in fall of 2010. But ultimately, we, after accounting for dropouts and after accounting for people who actually completed the whole survey and food frequency questionnaire, our sample size was around 33 participants. And we had about 6 participants in the focus group. These are some of the main findings of my study, and this model, again, has been kind of changed and adapted from the dietary acculturation model. So you see the socioeconomic and demographic factors here. Majority of my study population was between 18 to 30 years of age. A majority had been here for more than a year, and they were pretty proficient in English. Most of them originated from urban areas in India. Below that, you see some inherent values, like culture, religion, personal values, attitudes, knowledge, nutrition and health beliefs, certain health practices, eating patterns, and taste, which these women come with, so these are inherent in them. On exposure to host culture, you see this push and pull kind of a pattern that has been talked about in other studies as well. So there's some push factors which push these women into adopting the host country's practices. And so you see purchase influence was one, and eating out, again, was another. Grocery stores, food availability, specifically ethnic food availability, peer pressure, how open these women were to adopting the host country's patterns, their schedule, and transportation. So these were the factors that pushed them into adopting certain practices from the United States. Whereas on the other end, you had pull factors such as emotions and homesickness, longing for traditional foods, and then comfort level, how comfortable were they in their new environment, that kind of pulled them towards retaining their traditional habits. But the push kind of, you see, overcomes the pull, because when you look at the outcomes, there's an increase in bicultural eating patterns where they do maintain some traditional meals, specifically lunch and dinner, but breakfast was noticed to be more of American foods. There's a change in meal timing as suggested by other studies. They tend to skip meals and breakfast specifically. Change in food preparation. They tend to go for the quick and easy kind of meals, more of convenience meals again. The dietary preferences was observed to have changed as well. There were some students, vegetarian students, who after immigrating to the United States that do try non-vegetarian food. But so that was a shift, again, that was noticed. There's also a significant increase in weight gain, which I will talk about later. So all these factors could lead to potential outcomes like obesity again, and other chronic diseases such as type 2 diabetes, cardiovascular diseases, and hypertension. So this was one of the most main findings of my study. Respondents who immigrated more than 3 months ago reported a significant increase in weight. And this went hand in hand with a shift from their traditional eating patterns to that of more of Western Americanized foods, to more processed foods, foods that are high in calories and saturated fat. There's also an increase in the practice of maintaining proper body weight since immigration. This could be in an attempt to offset that weight gain again. There is a decrease in the practices of getting adequate rest and sleep, which is observed for all students in general, but there's also a decrease in eating traditional foods, which is again to be expected. Respondents also immigrated that the foods that they would like to eat are not readily available here. They started acquiring a taste for the foods here. They indicated transportation as a barrier to eating healthy foods and just for grocery shopping in general, and this was particularly for students who immigrated to the United States less than 3 months ago. Surprisingly, cost was not indicated as a factor for purchasing healthy foods, and most of these students came from medium to high income families, and other studies have validated this as well. They were observed to skip meals. They cook traditional meals less frequently because the preparation time required to cook traditional meals is more. There's a decrease in physical activity where they would just walk everywhere. In India, here, you just drive down somewhere. But they indicated that if they were to be provided nutrition information, they would modify their diet accordingly. And this is, again, very significant because this shows that they're open to receiving some sort of counseling or intervention programs. With regards to dietary diversity and variety, so we calculated dietary diversity and variety scores from the food frequency questionnaires. The dietary diversity score is the mean number of food groups consumed frequently in a week, whereas the dietary variety score is the mean number of foods in general consumed in a week. So the fruits and meat groups were the most commonly omitted from the food frequency questionnaire. Meat is to be expected because some of them were vegetarians, whereas fruits are surprising. And when we did the focus group, they said that fruits tend to go bad quickly, so we just don't keep them. Grains, dairy, and beans were consumed more on a consistent basis, and they're the staples of the South Asian diet. We see undergraduate had significantly lower dietary diversity scores than graduate students because most of them tend to eat in dining halls. And vegetarians, again, which is to be expected, had lower dietary diversity scores than graduates, non-vegetarians, respectively. We also found that the consumption of whole grains and olive oil, snacks, sweets, cheese, alcoholic beverages, coffee, and fruit juice increased, whereas consumption of traditional foods such as traditional spices, sunflower oil, Indian savories, Indian sweets, and ghee decreased. Those who migrated over 3 months ago indicated an increase in the consumption of meat, olive oil, and alcoholic beverages and fruit juices. Some of the key challenges that we observed were time constraints, a hectic schedule, transportation, food unavailability, rather perceived food unavailability, and lack of knowledge on where to buy foods, how to make healthy choices, what kind of stores are available here. So these were some key challenges that we saw. What can be done? Orientation programs is a good opportunity to reach this population. And information on meal planning, budgeting, cost-effective shopping practices, food labeling skills, or maybe skills on how to cook different foods. These could be included in such programs so that it would help them acculturate to the environment faster. We have a nutrition education program on campus, which is part of Orange Wrap, and maybe if they included an international student component to it, it would help these students as well. Social media, for example, Facebook. Facebook is everywhere. Everyone's on Facebook as well, so that's a good way of reaching them again. Cooking and tasting sessions, and another study did see that increasing the number of cooking and tasting sessions for international students does help them. grocery shopping trips. This is something that the university had started a few years ago, but they discontinued maybe because of lack of funds. But speaking to previous students, it did help them find out, identify different kinds of foods in the grocery stores and how to go about purchasing those foods. So this study in general will add to the research base of South Asian dietary practices, but it will also help nutrition professionals in identifying and evaluating the dietary risk factors that are influential in the acculturation process for these women. And it would help nutrition professionals develop nutrition education programs or intervention or different counseling strategies which are tailored towards student communities in general. Thank you.
So if Monica, Japna, and Karen would please come up here. We have about 7 minutes for questions. Yeah, we have time, so. Yes.
Okay. Well, I'll ask Karen a question, but I might be able to extend it to the others too, because I also, at certain points did interviews about the difference between village and city, but from the village point of view rather than the city point of view. But one thing that didn't come up in all those contrasts, I was actually struck by it. A lot of them are very similar, but in the city, these women say, we can't eat this, but they don't say the food doesn't taste good. I didn't really hear anything about flavor in your presentation, and I'm wondering if that contrast did come up, that is, food doesn't taste as good, or if the not eating is really just, the tension and the physical distress. But I did hear obviously the appetite comes back when they go to the rural areas and they get better. But do they ever talk about flavor? And I'm also curious, I guess, in terms of the difference in the pregnancy diets, because you hear a lot in the rural areas of North India about pregnancy cravings. Oh, I really wanted sour things, or I just had to have tomatoes. You hear a lot of things about that I often thought, well, maybe those are filling nutritional needs. And also just for these young women who seem to be eating less healthily, whether they talk about the taste. You did mention longing for certain foods, but how much flavor comes into it. So I guess it's across the speakers.
Well, when I was interviewing some of these students, they had quotes such as, oh, Americans eat too much of salt, they eat too much cheese. But these are salt and fat are two flavors that enhance the foods, the taste of foods. And they did seem to be choosing those foods over the other foods, even though if they did not want to admit it to themselves.
Put it in
Yes,
terms.
yes. And but my study or my population was predominantly from urban areas, not rural areas. But I think I had one student from Sri Lanka who was I think was from a rural area, and she held on to her traditional beliefs more so than the others. So, and she was not really open to trying out other foods as much as the girls or the students from the urban areas were. So I guess, like you talked about flavors, so maybe they're just not open to it that much.
Yeah.
They really don't want to accept it. Yeah.
I guess in my case, I can't think of any of the women I talked with mentioning flavors, but also that wasn't, I guess I didn't question them more about food because that wasn't my main focus of research. It was kind of a tangent. But also, I think I kind of took seriously this expression, which is a really common expression, like, kette bhal lagina or kette mone. These expressions that you hear people across, the Bengali-speaking world say. But in this case, is it just an expression? What does it mean in these different contexts? So like you were saying, is it a longing, or is it, very real that, as we discussed, they don't have, the time or the means to actually cook, or is it a loss of desire, or maybe it's a combination of all these things. So, that would be a great question to ask if I were to dig into that more. Yeah, I don't know I mean, it didn't come up, but
whatever
it's
it is,
possibly another layer.
Goes away when they go home to their dish.
Right. So I mean, I think it's a construction also as that almost as an escape from the everyday work world.
Well, if I can jump in. For my interview, when I interviewed the ladies, they mentioned that when they were pregnant, they would crave for like sour foods because they believed that it would relieve their nausea. So like tamarind was one of those things I heard. Also, they craved for like mango chutney, but they couldn't eat mangoes because it was believed to be a hot food. So they would really try to avoid certain things. So flavor was a big part because they said that during pregnancy their cravings were intensified. So I heard.
Tamarind, of course, is a very high vitamin C.
Right. So depends on how much they consume of it.
Yes.
My question is for Monica. I'm very interested in the issue of the food restrictions. In my own research in India, I find that very often doctors tend to blame women for their, for this sort of blind following of food traditions. This is how the doctors sort of represent it as being the cause for various negative health outcomes. And this is, my work was among very low income communities. So, very often it seems this is used to avoid having to address other types of issues related to poverty. I mean, if you look, for example, at anemia, people earlier were discussing anemia. It's not caused only by the restrictions of certain kinds of foods, but it's a major problem for maternal health. So I guess I'm just wondering if you could talk about sort of research that's been done that really demonstrates that the ways in which these rules are put into practice, in fact, leads to specific negative health outcomes. Because sometimes I think that there are certain things that the papaya, the mango, the pineapple that are avoided, but there are other foods that are eaten. So I guess my question is, what kind of evidence, what kind of studies have been done to really demonstrate that the practice of these things in fact lead to specific negative health outcomes?
There are various studies that have been done, but most of them, as you said, have been done on rural populations, not very much so on the urban populations, because as you can see, the urban populations, they're more geared towards they can go and access health care because they come of like, they're higher educated, they're working class women. Studies have showed that, I think it was NAG, one of the authors, she showed that hot foods were avoided, and she studied various parts of the rural communities in India, like Karnataka and Andhra Pradesh, and she said they were incorporating more cold foods which were viewed as beneficial, so like milk, yogurt, green leafy vegetables, which the women viewed as being beneficial to their baby, but there's no really scientific evidence to there's no studies really done on how this would be beneficial, but based on other nutrition studies, you can tell that milk and yogurt and green leafy vegetables are beneficial. So there's not really specifically studies that's been done, unless Dr. Raj knows specific studies that have been.
That's the big, the reason Monica was, of course, interested in this area, and this whole thing is, with the resurgence of Ayurveda and the humoral belief system, it exists, people follow it, it's followed from one generation to the next. The lack of scientific evidence makes us, sort of not want to view some of these things, but what is intriguing is that people who are immigrant women, sort of acculturated women, when they start following these practices, then you really want to dig deeper and see what is, is there some scientific basis to it? And nobody has, in fact, taken that step and tried to see, is there some correlation? I mean, in Monica's study, we found that the American, the US immigrant population versus the India population, there was more focus on the nutrition-based belief systems. Don't eat too much calories, don't avoid foods that are low in protein. So they were avoiding foods more from science-based. But at the same time, they were also avoiding foods based on humoral beliefs, that saying that this is hot and this is cold. So either is it because of experiential evidence that they have seen others follow it and they have seen some success with them or failure in certain cases? Is that what is directing their behaviors? Needs to be investigated. That really needs to be done. And hopefully, with the resurgence of Ayurveda, we'll be able to learn a little bit more about that. Is there scientific validity to some of these restrictions? In some cases, it's positive. In some cases, it's negative. So usually, hot foods are avoided because of destructive elements in such foods. So if they were choosing cold foods in opposition to the hot foods, it's actually beneficial because it so happens that all the cold foods are nourishing foods. So you have the grains, you have the lentils, you have milk, dairy products, you have green leafy vegetables. So I would rather that they follow those because at least from a nutritional point of view, they have some benefit to them. But things like, is mango really hot? We don't know. But in the Indian context, whenever you eat mangoes in summer, you also drink milk along with it. So you are eating a hot food, but you are trying to give an antidote along with it in the form of milk. So we don't really see the real ill effects of only eating mangoes. So one would have to do a very controlled study to see what happens to women who eat mangoes. Is there a problem with abortions, and which would be, I don't know, ethically how, it would be very difficult to do something like that. So that's the dilemma we are in right now. The Chinese have done some investigation from their Chinese medical therapy. So if we were to pick on some of those and study those, that might be beneficial.
I have a question for Monica and Jagannathan. So this morning, Dr. Ray talked about these, creations of cuisines that were the fusion of different types of cultural interfaces that occurred historically. So are you finding with South Asians who are here, is that happening with this interface with American culture? Is there a new sort of, is there a fusion that comes out of that? Or is it these women are either eating South Asian or they're eating American? There's no, do they create new foods? Or are they creating American foods with Indian ingredients, or the other way around? Or are they, how is that sort of working?
Yeah, that's interesting because I haven't really addressed that question in my study, but yeah, that is a good question. I don't think they're doing that as yet because for most of them, they're actually learning to cook when they come here. In my case, my studies sample were students, young students. And back home, it's mostly their moms who cook for them in India and other South Asian countries. So when they come here, just picking up a few basic skills and trying to whip up something quick and easy and fast. But I guess when they do get into the mood for cooking, they do incorporate other cuisines. But there's not a fusion per se, but it's more like trying to cook Mexican food or trying to cook Chinese food or maybe American food or something. But yeah, I didn't address that.
I wonder, Dr. Ray, why would that be the case? Why is there no fusion anymore? And
depends on the sample because my first book was Migrants Table, 126 households. What we quickly to give you a sense is it depends on what you're looking at. If you're looking at breakfast, there was a radical transformation to industrial breakfast in households because of the marginal utility of the time in the morning. If you look at lunch, there was massive Americanization. If you look at dinner, there was a massive Indianization of it, right? So in
it also depends on the location. So if you're in New York City, for instance, you have easy access to a lot of the traditional food. So you really don't need to experiment too much. You can just go in there, purchase what you want. But in Syracuse, still we had all the Indian grocery stores. A lot of women were quite innovative, and there were more Indian here than they would be in India, for instance. So, in preparing dishes, etc. But definitely people do include vegetables because you don't get the full complement of Indian vegetables that one would be used to. So things like broccoli, for instance. Broccoli is a new vegetable. It's not, it is available in North India, but not so much in South India. So it's a vegetable that you use. The greens, the kinds of greens are very different from what you would get in India. So people are innovative in a way. They try to see which greens would best suit the dishes, the traditional dishes. So there's a lot of alteration, there's substitution, so there might be omissions of certain ingredients and inclusion of other ingredients. So there are various patterns, as Dr. Ray says. Women tend to experiment quite a bit with the foods. At the level, when they're newer, they might not necessarily see the value in doing that. But as they are here and they come back, everybody, from all the acculturation studies, it's like a wave. At the first wave, it's almost like you don't want to see anything. You don't want to have to do anything with traditional food. So let's experiment with all the newer foods that are available. Then you have kids, and then when kids, their habits are being changed. And then later on, when kids leave, for instance, then you want to go back to your traditional foods. So, there's this going back and forth. And it's a very dynamic process, the acculturation process. So these students, the whole idea is during orientation process or, any of these situations, if they're given the right information, it's not necessary that they have to cook only traditional foods. But the idea that they would be able to use healthier foods in the mix is what would be the attempt initially.
I'd just like to add to that. I noticed more of an infusion, like you said, infusion of flavor with other cuisines. For example, these women would add red chili powder to make it more spicy, or stuff like onions and garlic to enhance the taste and flavor of that food.
I had a comment. I wondered if you looked at how people live, because I guess students usually they aren't living alone, but they're living in households, and I wondered if that affects it. Because I'm thinking lots of my Deshi friends, it's a group of people living together and you cook together, so it's still this communal practices. So whether it's people from different parts of South Asia, sharing food or mixing things together, or whether they're living with other Americans, or
so there's more of a fusion between the different cuisines in South Asia as well. It's a good thing you brought that up because in one of my focus groups, one South Asian student said that she's living with a Punjabi roommate, and Punjabis are used to having a lot of spices in the tea when they drink tea. So she used to drink bland tea, just tea, sugar, and milk and water. But with result, now she's been here for a long time, and that was just that initial year that she'd been living with her Punjabi roommate, and she started drinking tea with spices. So there's an infusion within South Asian cuisines as well.
Yes.
I thought I might add a little point on this. I'm a China boy, and so I have Chinese students living with me. And I know a good many of my Chinese students are online with mom every night. In my case, for the past 3 months, in order to cook authentic Cantonese food in a Western
No, I've noticed that with myself too. Since I'm an international student, I live with, well, I have a Chinese roommate, 2 Korean roommates, an American roommate, and then I'm a South Asian. And we sometimes cook together, and I'll make an Indian dish, and we'll have Korean dishes and Chinese dishes. But I always find myself adding more spices to my food just to make it tastier.
I guess I just have another quick question. I was wondering when you talked about having to learn how to cook here, because I know that's really common, especially for South Asian men, that they had never cooked. I mean, so many that I know, like they learned how to cook once they came to the U.S. But did you find that also for women? Is it a class thing or is it a regional? That they also learned to cook once they came to the U.S. or was that more for men?
Yeah, well, since I didn't study men, I can't really compare the two groups.
Okay.
But yes, South Asian females or women do. But like you said, there's the internet and there's Skype now, and you have the calling cards back home. So it's very easy to just call your mom up and ask her for recipes or tips while you're cooking, like what do I add now, what do I add next. But yes, men, I'm sure like some of my male friends do the same as well. Well, South Asian men are essentially mama's boys, so they don't really cook back home, and they, well, they don't really, their moms do everything for them, so I guess it's more of a novel experience for them when they come here and have to learn the way house. That's just my personal comment, I don't know, but studies have thoughts said about that.
Yes, Anand. Anand had a question and then.
Yeah, I'm just thinking on this thing and some of the things like, all the things of the and I have a small experience like, it's just my own like, own story. All this like, what you talk about like pregnant women and like, what the thing as a notion as a South Asian woman that what is hot or what is beneficial or not. When I had my first son, and my wife is American Italian like background. But after like first son, I had to go through like all the standard procedure here like as a couple like for all the pregnancy things. But after he was born, and she had been to India many times, has like read or heard. She tried like the turmeric powder in milk after birth, a couple of days. And then other things she like boiled this fenugreek seed in water and then cool it down and then like and she believed that like for lactation like the fenugreek seed water was good and the turmeric like helped her milk in something. And so it's not like she had any background there or something, but like somehow being in the culture or like studying there, learning and knowing that maybe there's no side effects, what's harm in trying it and see what's happening. So that was the one thing, like, that other thing. I was watching one day Dr. also, and I saw Deepak Chopra introducing Chyawanprash for, like, having something in the morning, like, to boost immune. Then other anecdote I had that I was in an Indian store, and I say, like, elderly person, American person buying bitter gourd, Karela, and telling someone that if you have the juice of this, like, it was like, Wednesday, and then the Wednesday that grocery store used to bring their, like, fresh vegetables. So it will help you in, your diabetes, like, that was something, and that's why you were buying bulk of that. And the other about if you cook them only, you can like experiment or like mix things. So if the life is not that you have no time to cook or do or like eat your food in car or in like while walking from one class to another or something, then I don't know. Then you some. But if you cook, then I have like sometimes I have pasta, which we generally cook, and then if I eat too much canned tomato, like tomato sauce, it goes Italian way, like tomato sauce, pasta, and then Parmesan Reggiano on top. I get hurt. So my recipe is like pasta with dal.
Wow.
Better than like so.
That's fusion. Okay. Cecilia, by the way, I'm glad he brought up fenugreek and he brought up bitter gourd, because those are two that have been experimented on and shown that fenugreek does, whether you eat it as a seed or whether you eat it in the form of a powder, it does decrease or have the ability to lower blood glucose levels. And bitter gourd, the vegetable bitter gourd, has been shown several times to lower blood glucose levels. So there's a lot of research on turmeric and saffron and cinnamon, and so a lot of the spices have been experimented on. So hopefully from that research, some of this will become clear, as you were asking.
Yeah, I mean, my point was actually
Yeah, I know, and you would like scientific.
that there tends to be assumption that there are negative health outcomes because of these
Yes.
so-called health restrictions, and I haven't seen much that has proven those negative health outcomes. I know there are things that have proven the benefits as much as it.
We had one last question at the back.
I'm fine. It was more of an anecdotal comment to the one.
You can share it with us, definitely, if they can dispel the myth.
I tend to agree, but I also say that I think Indian men do cook. It's just it's more of a function of how long sort of you've been outside India, and a function of how much you're able to spend money. So I think if you're comfortable, if you're slightly on a shoestring budget, you don't really have an option but to cook, and you learn how to do it, and your mothers tend to be quite helpful with it. But if you can afford it, then I think you do it in a more leisurely sense, and that is just because you don't have an incentive for it, because you're probably here for a year or 2 years, and it's just not you know that once you go back, you probably have a cook or your mother cooking for you or your wife, so it works out once you go back to it.
Yeah. So I guess we need to do a study on men too now.
Times are changing, so. Any other questions? Thank you very much. Thank you.